So now we're looking at Dupuytren's disease, or Dupuytren's contracture. And this is a proliferation of the palmar fascia. Therefore, it's nothing to do with the flexor tendons that move the fingers. It's all about the continuation of the palmaris longus, which then spreads out into the palmar fascia and some of the protective fibers within the palm. They start to change in their pathology and become contractile, and therefore, if I can just turn your palms up, you get a number of areas which are normally normal fascia contracting in certain set patterns. There are different chords, and the chords are the contracted abnormal tissue, and these often are in line with the fibers, and therefore the pretendinous chord, because it's in front of the tendon, can align all the way up each of the fingers from the palm, and they can start in a section here, a section there, or a section up in the palm. It's very variable on how they are expressed. You also have a thickening of the fascia over the abductor digiti minimi muscle, which is the ADM chord, Dutch digiti minimi chord, which is more up the ulnar side of the little finger. You have chords which tend to overlap and twist around the finger, called spiral chords, which do distort where the neurovascular bundle are. And then there is a number of chords you can get between the fingers called notatory chords, which are transverse between the webs, and commissural chords, which run deeper in this area and then across into the first web, which can cause some contracture of the thumb into the rest of the palm. You can similarly get pretendinous chords and such chords in the thumb. So that's the main aspect you're looking out for, is the chords. Then there's also nodules, which are thickened areas and more lumps rather than long straight lines of the fibrous thickening. And then there's pits. The pits are small dimples that you'll see around the palm sometimes, and that is because you get fibers that extend to the skin, and as the tissues contract, they pull that area or tether that area of skin down. When you're looking, there's also other aspects to Dupuytren's, such as Garrod's pads. Garrod's pads are a thickening which are often over the PIPJs, which look like calluses, but they're tethered to the skin. And then if these chords are present and they start tightening up, then the contracture or the positioning of the fingers can be noted. It's a difficult trap to fall into. You shouldn't really mention that someone's got a fixed flexion deformity by looking at them until you've actually tried to straighten the finger or asked them to straighten it, because you don't know whether they're just holding it in that position or whether it is actually fixed. For Dupuytren's, there is a number of different scars that you may be looking for. So often people have zigzag type scars, Brunner incisions, or Z-plasties, which are where the skin is moved to create some length in the finger when we have operations. In drastic circumstances where there is recurrent problems, you may have amputations, and as the disease is more ulnarly based, or it usually starts on the ulnar side of the hand, most commonly the little finger is the one to be amputated if that's the problem. And then there may be scars also from skin grafts. So you might find an area over the finger that has a different type of skin on it, so a skin graft from elsewhere, and it's often will have hairs growing from it as well, which obviously is not normal on the palm. One of the most common places for skin grafts is just from the crease in the elbow, because if you flex the elbow up, there's actually, on most people, there's a bit of spare skin there you can get, and the rest of the skin will stretch to cover it. On feel, Dupuytren's tends not to be tender. Therefore, palpation of it, you can feel that the Dupuytren's is tethered to the skin by moving it, but it doesn't tend to be tender, it just tends to be fairly firm. Also, part of feel can be the sensation. Sensation is not usually affected in Dupuytren's, but it can be affected if they've had previous surgery. So examining whether they have normal sensation on both sides of the fingers. So for example, on a normal finger, you can ask the patient, out of 10, with 10 being normal and 0 being no feeling at all, what does this feel like?
10.
10. And so if they've had an injury to a nerve, then you can then compare the finger that's been operated on to see if the one side is normal and the other side may be reduced or absent if that nerve has been injured. From a move point of view, often you're assessing the movement in Dupuytren's because there is a contracture of the fingers, which is why the patient has come to you, because it's inconvenient. First of all, you can ask the patient to make a fist, and usually flexion is normal unless they've had previous surgery that has resulted in stiffness or they have another comorbidity such as arthritis in the hand. And when they try and straighten their hands, often it ends up with one of their fingers, as I mentioned more commonly on the ulnar side, being slightly bent. And this can be flexed at the MCPJ, PIPJ, DIPJ, or all three or any combination. Once they've tried to extend it, therefore actively, you can see if you can push it further, but it shouldn't go any further with Dupuytrens because usually this is a fixed flexion deformity due to the fibrous tissue at the front. And then what you want to do, because you're comparing one progression but also any treatment results, is you want to see how bent those joints are. And for this we use a goniometer. You may be familiar with the larger ones for looking at hips and knees, but this is a small digital one. If I can ask you to turn your hand over, the best way to use these is on the back of the hand. Therefore, if I bend this joint to suggest a contracture at the MCPJ, I'll place the short arm onto the hand and just let the long arm drop onto the finger. Then I will try and straighten this finger. I can't straighten it anymore because of the contracture. And then I'll have a look that it's measuring around 30 degrees there. Similar with the PIPJ, if it's bent all the way down and I try and straighten it and it won't go any further, and that may be closer to 70 degrees that I'm reading off here. What you sometimes find is that the cord goes across both of the joints. This is then difficult to assess because it may be that the tethering is not causing a problem actually over both of the joints. If you have a contracture or the fixed flexion deformity of both the MCPJ and PIPJ, then they can be held in position because of the Dupuytrens, but also if they're held in that position for a long period of time, the soft tissues around the joints may contract also, especially around the PIPJ. Therefore, it's nice to know whether the joint is contracted or whether it's just the Dupuytrens holding the joint in that position. One way of assessing this is, for example, if the PIPJ I feel when trying to straighten the whole finger is flexed to around 45 degrees, I could flex the MCPJ to loosen off this cord or the thickening at the front and see if I can straighten the PIPJ anymore. Sometimes that'll be fixed, but sometimes it will come out straight because you relax the cord that is spanning over both the joints. And it's useful if that's the case to be aware that the PIPJ, which is often not very forgiving around the joint contractures, will be a bit more supple in this patient. There are two special tests that you can do with Dupuytrens. One, I'll just need to remove the pillow for because you need a flat, firm surface, and that is Houston's tabletop test. This is best done if I can use your other hand. So if you put your palm down on the table, it should get nice and flat. If you have contractures of the joints that are up here, you'll find that, like on my hand there, the palm cannot go flat, and therefore you get a positive result of the Houston's tabletop test. This can occasionally be deceptive because if you have a flexion contracture at the PIPJ, but your MCPJ still allows hyperextension, you can actually get with quite a marked contracture, still get your palm flat. So it's a useful and quick test, but it can be a bit deceptive if you have different variations of contractures. The final test that you might want to do, which is only really required if patients had previous surgery, is a digital Allen's test. So Allen's test is to test that the blood supply is good to the hand or the finger. So if we do a Allen's test on the hand first of all, if you see the hand is fairly pink, if I press it over, find both the ulnar and radial arteries and ask you to clench a tight fist please, and then press over the arteries, and then you can relax your hand straight. The hand's quite pale. If I take one thumb off, it starts to pink up. So I know the ulnar artery is plying the hand well. And if I can press over both of them again, if you can make your fist as tight as you can and then relax. Now release the radial artery and the hand pinks up again. So you know that both of these arteries are patent and filling the hand. It's a similar thing, but it's a bit more tricky to do with the fingers because the digital vessels are smaller, where you want to hold over both the digital vessels, then try and empty the finger so it's pale, and then you can take one finger off and see if it gradually fills, and the second finger. You can see it's got a lot pinker and quicker when I release both, but sometimes it will not change at all if one artery has been damaged in surgery.